what are biomarkers, and now we know, where is my, yeah, so now we know what are biomarkers and we know what is health disparity, right? Now we combine the two things, that how we can find biomarkers for precision therapy which includes all people, right? More diversity, okay? So for example, these are different kinds of patients and they have different biomarkers, and if you can identify the correct biomarkers, you are going to treat them completely differently based on their biomarkers, okay? So remember I told you about 4 things, so we have already covered this and we have covered this topic in details. Now we will look at these 2 more in details. So I will briefly tell you about biomarkers again, because this lecture was supposed to be on different days. Now we are combining because of that. So, I will go over these biomarkers very quickly, and then we'll look at some actionable biomarkers. So now you have very clear idea how we can exploit biomarkers for precision therapy. Without biomarkers, there is no precision therapy, because biomarkers are the one which tells us exactly what we need to use, how much we should use. So prognostic biomarker, it tells us what is the outcome of that disease, whether it is bad, whether it is good. Diagnostic will tell you which kind of cancer it is. Predictive will say what is the best therapy for this kind of cancer, right? Pharmacodynamics will tell us what is the best dose. If we are giving HDAC inhibitors, are acetylation levels going up? Is it hitting the target? Recurrence, it will also tell us whether this cancer is going to come back or whether it is not going to come back. So I already showed you diagnostic biomarker. For example, BRCA1 mutation, if it is BRCA1 positive, if KRAS is mutated, if p53 is deleted, right? These are all diagnostic biomarkers, okay? Prognostic biomarker, there is a new thing I have included here. So for breast cancer, I was working with a pathologist once. His name is Sunil Badwe. He's at IU Medical School. So he works on breast cancer. So he's mainly a pathologist. And pathologist, as you know, he works with cancer patient and he does biopsy. And when he gets biopsy, then he uses it for his own research to see what is wrong with this biopsy. So he was the one who introduced me to this thing. So there is a test, like a kit test, which is called Oncotype DX breast cancer recurrence breast cancer thing. So what they have done, they have seen in breast cancer these 21 genes are upregulated or downregulated. So they have made a kit to check these 21 proteins. So how we came across together, that I was working on aurora kinase, which is highly expressed in every human cancer, including breast cancer. And he was working on breast cancer, so I needed access to tissues of breast cancer. So remember, cells are okay, but tissues are the real deal, right? You have to. So that is how we set up collaboration. And he said, you know, your aurora kinase is one of the gene which is actually tested in Oncotype DX model. So imagine, out of the thousands of genes, if 21 are selected and your gene of interest is there, obviously it is very important gene, right? So Oncotype DX breast gene test for many different things, including HER2, aurora kinase also. And then they identify those patients who may benefit for Herceptin, for chemotherapy, immunotherapy, things like that, okay? So it depends the magnitude of chemotherapy benefit, it supports treatment decisions. So prognostic marker for Oncotype DX breast, a small sample of breast tumor tissue is collected and analyzed. So my friend was actually analyzing it, right? And so they measure the activity of 20 genes that are associated with cancer recurrence, okay? A recurrence score is calculated based on gene expression thing. So if it is higher recurrence score, bad news, lower, good news. So look at this thing here. So low recurrence score 0 to 25 indicates a low risk of recurrence, and chemotherapy is unlikely to be beneficial. So why chemotherapy is unlikely to be beneficial? So chemotherapy is given, chemotherapy is very toxic, okay? So if suppose somebody has localized cancer, you will not give chemotherapy. If it is localized, you would probably like to do surgery and remove it completely. And if you have to give chemotherapy, just give it to some extent, like even if their subcells escaped, they should be killed off, right? But you will not give chemotherapy. But if the tumor has spread everywhere, now you cannot do therapy everywhere. You cannot do surgery everywhere. The person is not going to survive, right? If it has gone to lymph nodes, now you have to give systemic therapy so that every cell in the body is exposed to the drug. Now you will give chemotherapy, correct? Because now it is literally a question of life and death, right? So when it is low recurrence, so you would like to do less aggressive therapy, clean it up, clean up the mess if it is localized. So that is why chemotherapy is unlikely to be used. Intermediate recurrence chemotherapy may be considered based on other factors. Really high, now you know you have to use chemotherapy for this patient, right? So by this one, this is just one simple thing. But suppose it is Aurora A kinase is overexpressed. Now you will give Aurora A inhibitors, right? This is also, Aurora A inhibitors are not FDA approved as yet, despite this being a very, very important target because they are very toxic, because Aurora is expressed in every cell of our body, okay? So patients cannot handle Aurora inhibition in normal cells, okay? So benefit is that it personalized treatment decision based on individual risk, whether we should give chemotherapy, whether we should give HER2 inhibitor, it tells you exactly. Limitation is that not suitable for all breast cancer patients, triple negative or HER2 positive cancer. So for example, there are many different kinds of breast cancer. So 21 genes is not an adequate representation to look at all the pictures there. So this is limited information. Still 21 genes is providing you limited information, okay? So does not predict the risk of distance metastasis. This 21 genes will not tell you whether this is going to metastasize or not, just because it does not have enough representation, okay? So I'm quickly reminding you about the biomarker. Since we studied just 1 hour ago, you already know the diagnostic, the prognostic, the predictive, pharmacodynamic. So I'm just going to go no response, right? Predictive biomarkers will predict whether a patient will respond. EGFR mutations, EGFR inhibitors, KRAS. So KRAS, if it is wild type, it predicts response to anti-EGFR because they talk to each other. And that is how you can predict different kinds of things. Okay, so you already know this is telling you survival. See, this is less survival, this is longer survival, right? So that is prognostic. Predictive biomarkers, if you have PD-L1, you know immunotherapy will work, right? Because PD-L1 will inhibit PD-1 and T cells will sleep, so you have to use immunotherapy, okay? So this is again prognostic predictive biomarkers, and so this oncotype breast cancer, similarly there are other kind of tests which will test. You also saw case studies where in this woman they have tested every different things. KRAS is wild type, ALK is negative, this is negative, right? So pharmacodynamic is the one which will tell us if you are using HDAC inhibitor, are acetylation levels increasing? If you are giving anti-cancer drugs, are Ki-67 levels decreasing, right? These are all pharmacodynamic. You are actually seeing if the drug is doing what it is supposed to do. If you give Gleevec, BCR levels should decrease. That's all pharmacodynamic biomarker. Okay, this is the figure I wanted to show you since morning. Okay, so this is there. So this is pharmacodynamic study here. So this is the baseline level of one marker. Okay, now you started the treatment, see how fast it decreased here, and then it slowly increased here, and now it is resistant. So pharmacodynamic biomarker is measuring, this is really good news, and slowly it is developing resistance and it is still increasing, right? Therapeutic biomarker act as a direct target of the therapy. So BCR-ABL is the target of imatinib, right, in CML, PD-L1. So if PD-L1 is expressed, we will use immunotherapy targeted towards PD-L1. Okay. Risk biomarkers are just predicting the risk. You already know that, right? BRCA1, BRCA2 is a good one. Safety biomarker. This is something I have not told you, but we will discuss this in details tomorrow. Okay. What are safety biomarkers? So, like I was telling you since morning, 10 people have identical drugs, identical disease, exactly the same stage, but we all will respond differently. Why we will respond differently? Because this is where the genetics come into play. Okay. So depending on our genetics, we may all respond completely differently to the same drug for the same disease. Okay. So, hydrocodone, have you heard of hydrocodone? Anyone has heard? I think hydrocodone or codeine, something like that. It is probably codeine. So when you have some surgery and you have really huge amount of pain in your body, codeine, right? Codeine, yeah. So like if you have dental surgery or any other surgery or any accident and you have huge amount of pain, people are given codeine, okay, to control that thing, and people get addicted to that codeine and they can never get out of it, and that is what leads to drug abuse. Okay, and that is a very serious reason. I know many people, I don't know any of them personally, but I know their friends or family personally. So somebody met with an accident and the hospital doctors give them these kind of drugs like morphine or something, and then they got addicted, and that time the doctor was giving them because they could not survive with that pain, and then they got addicted, and now they cannot live without that addiction, right? So but at the same time you give codeine to other people, they will not get addicted, and every time you give them codeine they are going to throw up. So other people are enjoying codeine and these people are throwing up codeine because it is just really toxic to them. So they have the same disease, but they are reacting very differently, right? That is because of our genetics, okay? And we will discuss that in great details tomorrow. That comes under pharmacogenomics thing. So if we incorporate pharmacogenomics there, then we can predict exactly. So suppose we do our genome thing, like they don't check the whole genome, they check maybe 20 things there. And those 20 things will tell them exactly, should I give this drug to this patient? And they will know, no, this person cannot use this drug and this person is going to feel worse about that, right? So that is what is, they say that if this person has this mutation, this drug is for HIV, this person cannot tolerate this drug. So if somebody has HIV, they do a quick genetic test, PCR, 1-day test, and they will know you cannot give this drug if this person has this mutation there. If they don't have this mutation, this drug will be phenomenal for them. Okay, for this one, you cannot give it to some patient who cannot tolerate this drug. This is just due to mutation in subgene. Okay, tomorrow I will give you that. So this is also, that is risk biomarker, which I did not tell you before. So now we know about all the biomarkers, we know about precision therapy. So let's go and really look at some cases here. So now we will look at eliminating precision medicine disparities by identifying actionable biomarkers. Now we are combining the two things, disparity in health research and finding the biomarkers for that, so that we can find the exact thing. So role of actionable biomarkers. Actionable biomarkers means molecular or protein markers like DNA, RNA, metabolite, whatever it is that guides specific treatment decision. EGFR mutation means you have to use EGFR inhibitors for in lung cancer. HER2, Herceptin. BRCA1, PARP inhibitors. Identifying them levels the playing field, ensures patient get the right drug for the right patient at the right time. Okay, so how do you identify actionable biomarkers to reduce disparities, early testing, universal biomarker screening and diagnosis prevent missed opportunities. Okay, population inclusive panel. It is very important that we have the complete picture for all across the board, all kinds of patients. Okay, so for example, it is possible that people of Asian origin, when they, maybe we don't even know as of today, that people from India versus China versus some other Asian country, we have different kinds of mutation, right, in some gene, and we may respond differently because of those mutations. But if we know in advance, then we know exactly what to give. Okay, so population inclusive panels, designing biomarker assisted validated across diverse ancestries. Liquid biopsy, that is the best thing. You just take out the blood and you figure out what the disease is. You know, we had a faculty member in our department. He has now retired. He's a very famous chemist. His name is Fred Rainier. So he was a mass spectroscopist, right? Analytical chemist, world famous analytical chemist. But he was very interested in biology. So he was studying glycosylation pattern. So glycosylation patterns means proteins are decorated with sugar and they form all different things. So he found, and that is about 20-30 years ago, so that was extremely novel at that time. He was one of the first person to find that glycosylation pattern is different between normal and cancer patients. So obviously it is not easy to get access to cancer patients. So he used to work with dogs with cancer. So normal dogs, dogs with cancer. And then he took their blood, and he was a mass spectroscopist, right? He's the one of the person who developed all these huge techniques for mass spectroscopy, right? So extremely bright guy. So he showed, and he was telling me, by the way, he set up my LinkedIn page. I never wanted to come to LinkedIn, and he said, you have to come. You have to come. This was, I don't know, 15 years ago. Since that day, I've never been there. But he was the one who created my LinkedIn page, and I'm still what he created that. So it has never been updated since that date. And I cannot delete it. Once it is there forever. You cannot delete it. Okay, but he was my friend. So he was telling me, you create like this big chip something, and I don't know how it works, but you take the blood from normal versus the diseased dog, and by looking at the glycosylation pattern, the sugars that are shed in the blood, you can predict cancer even before it develops in the dog. Okay, so it was really, really powerful. So if you can develop non-invasive thing, people are more likely to get it tested. If you say they have to do a surgery to get the biopsy out, they are not likely to do it, right? And of course, education and awareness about these diseases is very important. Training clinicians and empowering patients in underserved communities. Okay, so improve diagnostic across population, personalized treatment access to all. Reducing trial exclusion bias, cost effective is very important, especially if insurance company is not there, or if by the way, healthcare is best in Europe, not in US. In European countries, healthcare is absolutely the best. You can get extremely good healthcare, equal to all. Okay. And monitoring and following up is very important. Okay, so this is all the same things that I have told you today. They are all listed here. So I'm not going to go through this, but you can read it here. We have covered all these topics in detail today. Okay, we have to have standardized care guidelines, improve treatment selection, enhance drug discovery. The use of biomarkers have shown to increase the success rate of clinical trials. Okay, accelerating the development and FDA approval of new targeted therapies. Okay, it is very important for community engagement and awareness. So these days, you know, I'm sure it is here too. There are many funding agencies. They will give you money if you have some component to raise awareness, to engage community, to educate them about diseases. Okay, so this is very good. Let's look at case studies. That is where it gets most interesting. So lung cancer in African American patients, historically low rate of EGFR testing compared to white patients. So this is the story I was telling you, that this black woman had lung cancer, or I think she had breast cancer. So instead of checking for HER2 or EGFR, HER2, EGFR, they belong to the same family, by the way, right? So instead of checking that, they just gave her chemotherapy and she died. And if they would have given her the right drug, she would have survived. Okay. Case study 2, EGFR mutation in lung cancer. This is interesting. Never smokers Asian population. Now, Asian population is misrepresented in clinical trials, so they don't even know. So, disparity, lung cancer in Asian and never smoking patients was under recognized. So, chemotherapy was given because they didn't even know. These guys have never smoked, nothing. They gave chemotherapy. The person, these people, they died eventually. Okay, but the actual intervention would have been EGFR testing because it is due to EGFR, and they never tested EGFR, so they just gave them chemotherapy. Okay, also it is true that many times even the hospitals are there, even they have access, they are not willing to test it for you. Okay, they will just give you chemotherapy unless you put some kind of pressure. No, you have to test it. This happened to someone I know extremely well recently. Okay, this is a gone case. No, we are not going to even worry about it. And then the son was so good. He said, no, you have to. So he got a lot of people involved. And basically, they had to change the whole regimen. And this person survived. Okay, so sometimes you have to also push it to go in the right direction, especially if you have knowledge. And the funny thing was that the son is an IT person, so he has zero knowledge of biochemistry. So he used to talk to me all the time. So I was the person who was guiding him, and the second person who was guiding him more than me was ChatGPT. So he studied everything in ChatGPT, and then he would call me, Didi, I read this and this and this, and we would discuss it. I said, use ChatGPT, but ChatGPT can mislead you too. But he would just put everything in ChatGPT, and then he would talk to me. And I'm so proud of this guy. He just saved his father because he was so adamant. Like he took he's in US, his sister is here. The sister took the father to Max Hospital in Delhi, and they would not look at him. And he lives in Kanpur, and they took him to Delhi. They would not look at him. This is a gone case, this and this. And this guy, the son, he talked to people in Seattle. He talked to doctors in Chicago. ChatGPT was guiding him all the way, what to do, what not to do, and everything. And he paid them. He paid these guys, got all the reports. He did all the recording. He was sending me the recording also, so that I can hear everything in the original format. And then he was talking to them like everything. Can we do this? Can we do this? What is the option? This doctor said there is 1% chance, and the first thing this guy said, which brought tear in my eyes, oh, there is 1% chance. Oh my God, I thought I cannot take because it was just too much for me to take that. But the bottom line is that this person survived, because now the doctors in Max Hospital said, oh, these people's top oncologists from US are involved. Now they are paying attention, and before that they were shouting at at this guy's sister, So sometimes you have to push the system to get the right therapy. It is out there. If somebody says it is not going to work, it doesn't mean it is not going to work, So, all right, let's go to case study 3, BCR-ABL. BCR-ABL, we know drug is out there. So if you identify BCR-ABL, so disparity, because it is a leukemia disease, right? Chronic myeloid leukemia. So you have to do bone marrow transplant. But if it is inaccessible, obviously it is a bad thing. But at least intervention is very simple. Simple PCR testing. BCR able will come in a day. In a lab, you can know in 2-3 hours if that is the problem. You make a primer towards BCR thing and able where they are joined together. If it is positive, you know it's BCR able, right? And off the shelf drug, I mean not commercially available, obviously the oncologist has to prescribe it, but this is very important to do this kind of testing. So strong actionable biomarker, simple assay, equity, anyone can access it. It is not expensive. Gleevec is expensive, but okay, the testing is not expensive. And I'm sure Gleevec will become generic soon, then it will be very cheap also, right? HER2 in breast cancer, you already know Herceptin, right? Okay. This is another case. So I briefly told you about this. This is a HIV medication. So it is a very effective medication, but you cannot give it to every person. You cannot give it to every person. Few people are going to react so badly, and I will tell you why tomorrow, okay? But before giving, even if it is positive and even if you know everything, you cannot give the same drug to every person. They still require some genetic testing. If you have that knowledge in advance that some people may react badly, you need to test it. If you don't have that knowledge, then you don't have that knowledge, then we will not know in advance. But if you have, you need to check it, okay? Wow, that is a record, okay.